This is the Postgraduate Pediatric Orthopaedic video series. I'm Sattar Alshryda. I'm a pediatric orthopedic surgeon. In this video, I'll take you through the radiofrequency ablation of osteoid osteoma using the Q-guidance navigation system from Stryker. And this is part of chapter 20 from the Postgraduate Pediatric Orthopaedic. In general, there are two ways to do radiofrequency ablation. One is using the navigation and one is the conventional one. And I believe the future is the use of navigation system because of the ease and the accuracy of procedure. Osteoid osteoma is a common benign osteoblastic lesion of uncertain etiology. It is more common in male in a ratio of 2:1, and the symptoms are usually typical. Chronic dull ache pain, typically worse at night, and respond very well to non-steroidal anti-inflammatories such as ibuprofen or diclofenac acid. X-ray often demonstrate a radiolucent nidus surrounded by a dense sclerotic bone. The nidus is typically less than 1.5 cm and may have a central region of mineralization. These may be only seen on a CT scan images. Osteoid osteoma is a self-limiting disease, but spontaneous improvement might take several years. CT-guided radiofrequency ablation is the treatment of choice with a success rate of 95% of the cases. Open surgical resection is generally not recommended unless the lesion is very close to a neurovascular structure that cannot be pushed away from the lesion, and it has the advantage, the open surgical resection has the advantage of histological confirmation in comparison to the CT-guided radiofrequency ablation, which is typically have a difficulty in obtaining samples. Osteoblastoma and osteoid osteoma are histologically identical. They are very close resemblance to each other. They have the same symptoms, but the difference is that osteoblastoma is larger, usually the size of 2 to 10 centimeter. 30 to 40% are found in the spine, particularly in the posterior elements such as the spinous process, the pedicles, and the treatment consists of a curettage or local excision. The risk of recurrence often is 10 to 20% after surgical excision in osteoblastoma. Our case for today, which we're going to use to demonstrate the technique, is a 15-year-old girl who had typical clinical and radiological features of osteoid osteoma, treated with conventional CT-guided radiofrequency ablation. She had full resolution of her symptoms for 2 months, but the symptoms recurred. And when the symptoms recur, they are very typical. Night pain that relieved by non-steroidal anti-inflammatories. And we decided this time to treat her with a radiofrequency ablation using the navigation system. Airplane X-ray was unremarkable. You cannot see anything. There might be some sclerosis where the lesion is, but otherwise it's essentially normal. The MRI scan showed high signals within the femoral neck and some joint fluid, as you can see in this video. And here I'm pointing to the edema of the bone. There's some bone thickening at the front, as you can see in this dark signals, and there's slight hole, as you can see here, which is where the nidus is. A CT scan showed typical features with a nidus surrounded by sclerotic bone, as we can see in these sections of the CT scan. And on the coronal sections, again, we can see it at the bottom part of the femoral neck. Again, typical radiolucent area of less than 1.5 centimeters surrounded by sclerosis. And again, on the axial section here, as we scroll down, we can see the track of the previous radiofrequency ablation using the conventional way, as pointed by the red arrow here. And just beside it, we can see the nidus. Here you can see the mineralization within the nidus, and the nidus, as pointed by the green arrow, it is less than 1.5 centimeters surrounding by sclerosis. And in one of the sections, you can see the central mineralization. Again, I'm going to scroll back just to demonstrate it better. You can see the nidus surrounded by sclerotic reactive bone. And probably with the eye of faith, if you go slightly high up, you can see the central mineralization. The CT spectrogram can demonstrate the high signals within the nidus. You can see the dye is accumulating in two areas, the bladder in the center and the center of the neck of the femur. So these are typical features for osteoid osteoma that is still active. In theatre, we position the patient's supine or radiolucent table. I usually prefer to use a chlorhexidine because it is superior to betadine. Once this is dried off, we use disposable draping. The edges of the draping usually has sticky material that make it attach to the skin, but this is not as effective as IOPAN. Thus, once I finish the draping, I usually use IOPAN, cut it into small strips and stick the edges of the draping to the skin. This is usually more secure and prevent inadvertent detachment of the draping from the skin. And I hope this would reduce the infection. As you can see, there's a small previous scar from previous conventional CT guided radiofrequency ablation, which is done in the department, which will be the subject of a separate video for people who doesn't have access for the navigation system that we're going to demonstrate in this video. In our hospital, we use the Stryker navigation system, and there's a full video made by the company, and we keep the link for how to set it in the comment below. But we strongly recommend anyone who planning to use it is to attend the training session. Usually it's 1 day of training session, and when you do the first cases, try to invite one of the company rep who are very familiar with the system to help you with the setup and the support through the procedure. The focus of this video is the procedure itself rather than how to set the system, but yet we still demonstrate some of the key part in setting the system. After preparation and setting the system have finished, we start our procedure. The first part of the procedure, we need to identify the involved bone to the system. And here I usually use 2.5mm threaded tip wire. I insert it to the bone that carries that particular osteoid osteoma. And I use this to connect it to the patient tracker that would be identified to the system. From my experience using a single wire, it might not as good as if using two wires next to each other. Using two wires, it gives more security and more stability for the patient tracker device. Although it is obvious that we should connect the tracking device to the bone of interest, which is the femur in this case, we don't recommend attaching the tracking device to the pelvis or to the tibia for obvious reason. That's once we secure the wires, we attach the spinal clamp to these wires, and to this spinal clamp we attach our ingenious tracker system, and this will be identified to the navigation system as where the bone is attached to. And then after that, we start the registration of the patient, and here we used the Stryker trackerless automatic registration. Here there are 3 dimples on the Ziehm machine or the 3D scanner where we identify them to the system. And the system should register accuracy of less than 2mm. In this case, we get an accuracy of 0.09mm, which is good enough. Once we finish our patient registration and establishing the accuracy of our digitalization process, we move to the 3D scanning of the bone of interest. We use a Ziehm 3D scanner because it's compatible with the Stryker navigation system, and we scan optimal amount of the bone, so some of the bony landmark will act as a cross-check for our navigation system. This process usually takes around 8 minutes or so, and it's ideal for all the staff to leave the room, so to reduce the amount of radiation exposure. Next, we need to calibrate the calibration device using the pointer, and here we put the tip of the pointer to certain points on the calibration device, and the company rep tried to validate it on the screen, as you can see in this video clip. And here the calibration device has been calibrated. The next and probably the most important part of this procedure is to create a device that would take us to the osteoid osteoma. And this is the innovative part, because this device was designed to do the spinal surgery, not hip surgery. And it's really simple. Just simply connect the 2.5 threaded tip wire to one of these Stryker navigation devices and fasten it securely. Then attach the whole device to the ingenious tracker system. Then the next step is really to identify this newly developed device to the navigation system. using the calibration device. Here we try to identify how far the tip is from the ingenious tracker system and the size of the wire that we used. Once we finish this process, then the next step will really to identify the accuracy of our system again. This can be simply achieved by touching the pointer to some bony landmarks such as the anterior superior iliac spine. Then checking on the navigation screen that the touching point is exactly what we expected and it's accurate, as we can see in the three-dimensional figure here, and the sagittal plane, the axial plane, and the coronal plane. We can use another bony landmark, or we can simply use the wires that attach to the bone and make sure the accuracy of the system is spot on. Once all this completed, we start with our procedure. And here we use the device that we created earlier to go percutaneously to the neck of the femur and under the direction of the navigation system to the osteoid osteoma. And from the top left corner where you can see the navigation screen, it can be easily followed to the exact position of the osteoid osteoma because we can see the axial, the sagittal, the coronal, and the 3D imaging of the bone. And this is what makes the whole procedure easier. One drawback of this technique is that the fact that the K-wire is attached snugly to the tracking device, we cannot use the drill, and we have to use a hammer to hammer the tip of the wire into the bone. Again, this is not a complicated, it's simple and straightforward, and that the guide wire can easily go through the bone by the hammering process. But we are working as well on a jig that allows the drill to be used. And here I'm trying to use my device by using the navigation system to be exactly in the direction where I want to be. And my assistant used the hammer to hammer the tip into the osteoid osteoma. Once we think that we reach the area of osteoid osteoma and the tip of our guide wire exactly in the center of the osteoid osteoma, we repeat the CT scan to ensure that we are in the right place. And here is our CT scan pointing the fact that the tip is exactly where we want it to be. And even we can correlate this with our scanogram from preoperatively. And we are happy with this position. Then we move to the next stage where we need to drill the bone to that area. And then we use this 4.5 drill and we go all the way down to the osteoid osteoma. Make sure that you don't dislodge your K-wire or your guide wire because it's really important to stay in the right place. Then we use kind of a tracker down through the bone and we remove our guide wire. And when we remove our guide wire, we put the spinal needle just to be absolutely sure that it goes through our guide and it is in the right place. Once we are happy with the position, we introduce the electrode into the lesion. In our hospital, we use the Osteocool Bone Radiofrequency Ablation system from Medtronic. And these, they come with the different sizes and they are color coded. In this example, I use the low color code, which is 7mm of radiofrequency ablation. Of course, for bigger lesion, you can use bigger sizes. But you need to be careful with the nearby structures such as nerve or vessels and not to damage them. Then we apply our thermal ablation, and this is usually at 90 degrees centigrade for a total of 4 to 6 minutes. Here the video has speeded significantly for the sake of time. Then when we finish the 5 or 6 minutes, we remove the electrode, we instill some of local anesthesia in the joint, and we wash the area and we close it with absorbable sutures. Dressing will be applied as per normal. Patient after surgery, they can mobilize as tolerated, but we advise them not to do any contact or tackling sport for 6 weeks. We give them simple analgesia such as ibuprofen and paracetamol, and we review them in 2 weeks' time for a wound check. And this will take us to the end of our video. I hope you find it useful for your exam and for your practice. And on behalf of the Postgraduate Pediatric Orthopaedic Board, we wish you all the best for your exam.